Next, we're going to talk about blood transfusions and kind of what the nursing implications are around patients who are getting blood transfused. So, what is a blood transfusion? This is where we give whole blood or blood products to a patient who does not have enough circulating blood or blood product in their body naturally for whatever reason, whether it's a metabolic reason like they're not producing enough, or a traumatic reason like they've recently lost a lot of blood. Sorry, pacing got weird. One of the big things, there's a very high risk of complication around blood transfusion, particularly associated with the complacency that comes about from just verifying the blood products. It's one of the biggest risks that patients are exposed to is getting the wrong type of blood product because nursing staff or any medical staff doesn't appropriately verify that it's a correct and safe transfusion to give a patient. Two different ways that patients can receive blood transfusions or kind of categories of the products that they get. So there's homologous transfusions, which are transfusions from another source. So this is a blood bank. This is what most patients get. Words are getting hard. Autologous transfusions are where the patient provides their own blood sample. So patients who knowingly go into big surgeries where there's an expected amount of blood loss can donate their own blood for autotransfusion during that procedure 4 to 6 weeks prior to use. So they can donate their own blood, which will be readily available for them during that procedure 4 to 6 weeks ahead of time. So that's the two different ways that patients can get blood transfusions. There's also some fancy ways that we can do like surgical blood collection post-operatively and retransfuse that to patients. But that's much more of a specialized equipment orthopedic thing. We're not going to be covering that in the general blood transfusion type skill. This is why complacency is such a problem. As a nurse, every one of these barcodes needs to be verified in order to make sure it is safe to transfuse this blood product for a patient. So we need to verify the product itself, the order, where it came from, who it's going to, all of these things. It must be done by 2 nurses to verify every one of these components. And usually there's about 6 different line items that we have to confirm before we can even spike the bag on the IV tubing. So there's a lot that has to go into this, and we have to be really diligent and make a conscious effort to be really diligent to make sure that this goes safely for our patients. So the different types of products that patients can get. They can get whole blood, which is just kind of all the components of blood, where 1 unit of whole blood should increase their hemoglobin by about 0.5. Packed red blood cells is the most frequently given blood product that we use. So this is usually 1 unit is about 250 to 350 mils. Depends on the unit, they vary a little bit, but they're prepared from whole blood, but it is just the red blood cell or the hemoglobin components that are being transfused. 1 unit, we can expect about a 0.5 point increase, if not a little bit more, from a transfusion. Then we can give platelets, much smaller volume, that can be used for patients with clotting disorder or low platelet counts. FFP, or fresh frozen plasma, which is the liquid portion. So it's not necessarily the hemoglobin component, but it's a lot of the other circulatory components. And albumin is also considered one of our blood products that we do need to take into consideration. Key thing here, the rate of infusion during the first 15 minutes is very different than the rate of infusion for the remainder of the transfusion. That first 15 minutes is the most dangerous part of any blood transfusion, regardless of the product. So we always infuse very slowly for the first 15 minutes prior to opening up the transfusion for the prescribed transfusion rate. And the prescribed transfusion rate, usually it's not a like give it at this many mils per hour kind of thing. A lot of facilities do transfuse 1 unit over 3 hours. So this is, this is where med math can absolutely still be a thing. Had a big gulp of water before I started this one. Sorry about that. So transfusions must be completed within 4 hours of receipt of that blood product on the nursing care unit. So time to receipt to time to completion of transfusion must be within 4 hours. But the first 15 minutes are a very, very slow rate where we're providing direct care to our patient in observation. But we'll talk more about that kind of stuff in just a second. So people who can donate blood have to be adults. That's kind of a thing. Have to be in good health, can't have an active infection, and have to have stable vital signs. That's the big thing. You can look at a complete list right here at this website for all the whole rules about who can donate blood, that kind of thing. But the general thing is like you can't have diseases, you have to, you can't have active infection, and you have to be in good health are the big ones. So administering, when we're going to give blood products, this is what our setup looks like. Again, there's special tubing for a blood transfusion. It's this Y connector type tubing. So there's 2 spikes on that bag, or on the tubing rather. One is for normal saline, and normal saline is the only fluid that can be hung with blood products. Can't be any other type of fluid. The other spike is for our actual blood product. And what we'll do is we'll prime all this tubing with the saline, and then we'll close off the line for the saline and open the line for the blood product, and that's where we'll begin our transfusion. And we always control the rate with the lowest possible clamp, not the clamp up high next to our blood product bag. But that's what that'll look like. So 2 big chapters in how the activities go around a blood transfusion. Chapter 1 is all the things we do outside the room. So before we bring that blood product to the bedside, the things that we do. 1, review the patient's history of transfusion. We're looking for any past transfusion reactions or any past history of transfusion. Is this the first blood product they're getting, or is this one in a series of blood products that they're going to be getting? And then any relevant lab work. So we want to look at their hemoglobin hematocrit. So if somebody's, I always get these backwards. If their hematocrit, got it, is less than 20, then that's usually criteria for when we want to transfuse, meaning their hemoglobin would be just under 7. Because if a patient is adequately hydrated, there should be a 3-to-1 ratio of hematocrit to hemoglobin. So hematocrit will be 3 times what their hemoglobin will be. So if we get one number, we can kind of predict what the other is, but that's also what we always want to look for to determine whether a patient is adequately hydrated around their blood, circulating blood. And then we want to confirm that the consent for transfusion of a blood product has been signed and completed. So we've reviewed whether they've had a transfusion. We've looked at their lab work to make sure it's appropriate, and we confirm that they've got a consent and that there's an active order for that transfusion. Then comes all the things we do in the room for that blood transfusion. And there's a lot of them. So the first thing we need to do is gather up all our equipment. So the patient needs to have at least a 20 gauge IV to transfuse. Anything smaller than a 20, which would be numbers bigger than 20 because it's backwards, is not appropriate for a blood transfusion. Then they have to have blood tubing and administration set, which is just this, the saline with the double connector tubing. And the only compatible solution that we prime that set with is saline, correct. Maybe a pressure bag, which is just an inflatable bag we can put around the blood product to help squeeze it in a little faster. But in an acute care setting, you're not going to use that. That's really only for emergencies and critical care that we're going to be doing that. Same with a blood warmer, where we have to warm up that blood product for infusion. That's really for rapid transfusions, not for routine ones. But these three up here, numbers 1, 2, and 3, absolutely must be in place in order to make sure you have all the equipment to transfuse. Step 2, get a set of vitals. This is our baseline set. The big risk with any blood transfusion is what we call a transfusion reaction, meaning the patient is having like an allergic reaction to the blood product. So this baseline set is our comparative marker for any set of vitals thereafter. Then we do an assessment, heart, lungs, and any signs and symptoms of transfusion reaction. We're going to get into those signs and symptoms in just a minute, but those focused exams are the things we want to look for. Then we can verify our blood product. 2 nurses checking all of those barcodes, checking the patient ID, all that. This is the part where complacency becomes a big risk for our patients. Then we can start the transfusion. We're going to start the infusion of blood, so when the blood reaches the patient, we're going to be infusing that at a very slow rate for the first 15 minutes. During this 15 minutes, the primary nurse for that patient must stay at the bedside, assessing and monitoring that patient for any signs and symptoms of transfusion reaction. Reason for that is the first 15 minutes, if the patient is going to have a bad reaction to the blood product, that's when it's going to happen. And we're going to have to intervene very quickly. So we always provide direct observation for the first 15 minutes of the transfusion. At the end of that 15 minutes of that one-on-one observation period, we recheck vital signs and the assessments to make sure our patient's condition hasn't changed, to make sure they're still hemodynamically stable and symptoms don't give us any cause for suspicion that the patient is having a reaction to that blood product. If all of that is negative, then we adjust the infusion rate for the completion time so it's done within 4 hours of arriving on the unit. So, other rule with that is it has to be started within 30 minutes of arriving on the unit. So you can't get your blood product, go to lunch, take care of some other stuff, pass some meds, and then 2 hours later start your blood product. It's got to be started right away, and it has to finish within that 4-hour window. And then at the end of the transfusion, when it's all done, we're going to repeat all the vital signs and our assessments. We repeat step 3 at the end again for that final comparative evaluation of how our patient tolerated that blood transfusion. So here it all is. So we've got our blood, our saline wide into our patient. He's nice and happy. We're administering within 30 minutes. We can't add any medications to this blood tubing. It has to just be the blood. Here's all the verifications that we need to do. Here's all of our 2 nurse checks for our patient, all 6 of those items, which is routine for every care facility. And we do not kind of warm or get into any of that kind of stuff unless there's a risk of hypothermia, which is really a specialized situation. We don't generally worry about hypothermia in a patient. And they've got to be completed in less than 4 hours. Must be done within less than 4 hours to have a happy transfusion. Here are the complications. We can have immune and non-immune related transfusion reactions, but the ones that we are most concerned about are the acute immune-related interactions. So things like a hemolytic reaction, meaning that the body is attacking that blood product and preventing and causing a massive histamine response, like an allergic response to that blood transfusion. This can either be febrile or non-febrile, but we always want to look out for those fevers that are indicating a transfusion reaction is going on. And anaphylaxis. So a full-blown anaphylactic reaction, allergic reaction to that blood product is another one of those things we're looking for. And all of these are going to start to present within 15 minutes of initiating the transfusion. The rest of these types of reactions for our non-immune mediated responses or complications, these will present in the transfusion window, so within the 4 hours before that blood product is completed. But our delayed ones, they're going to be 24 hours to a week after transfusion. So we're not looking out for these in the hospital setting. Rather, these are the ones that we're really looking out for when we start a transfusion on a patient. The likelihood of a blood transfusion reaction is not high. It's very, very rare. I've seen 2 transfusion reactions in like maybe, I don't know, I would guess maybe over 100 units transfused in my practicing career, and I've only seen 2 transfusion reactions. And one of them was a febrile reaction, and the other one was actually a false reaction. But we still treated it the same way. They're very, very rare. Odds of having a febrile non-hemolytic reaction, which is kind of the least severe of them, is 1 in 1,000. Anaphylaxis is the one that we get really concerned about because it's the most severe for our patient. Like, anaphylaxis is a life-threatening emergency. Their odds are only about 1 in 50,000 of developing that. It's kind of like the risk of getting AIDS out in the community. Similar risk ratio. So it's not a high risk of having a transfusion reaction, just to kind of put that in perspective a little bit. So when things are going bad, now he's unhappy, we've got our blood transfusion reaction. For our febrile reactions, things we're looking for, signs and symptoms of fever, especially tachycardia, flushing, and objectively measure of a fever. Some of the common things that we look for hemolytic reactions, lower back pain is a common symptom that patients present with, so we always ask about lower back pain. If patients have chronic low back pain, we're looking for a change in their perception of their back pain. Hypotension, tachycardia is a big one. Fever, it's a big one. Fever, tachycardia, shortness of breath, feeling like their airway is closing are the common symptoms that I teach patients to look out for when I do those transfusion reaction questions. Before initiation of blood product, 15 minutes in, and then at the end are the routine times that I do that. If a patient does give you any signs and symptoms of a transfusion reaction, step 1, immediately stop the infusion. So stop it right where it is and notify the physician. While you're notifying the physician, hit start on the vitals machine and check their vitals. Make sure you have a full set of vitals to report with those patient experience subjective findings for a transfusion reaction. If you really suspect that this patient is having a transfusion reaction, what we need to do, because like a common one is that most protocols say if a patient's temperature goes up 1 degree from the start of a transfusion and then to your first check, you need to stop and notify the physician of a potential transfusion reaction. Most of the times we'll do that. We'll stop the transfusion we'll stop the transfusion, notify the physician, and they'll say, okay, well, let's give them some Tylenol and restart, because all the other symptoms are not present. And a 1 degree change in temperature doesn't even necessarily mean they're febrile. They may go from 98 to 99. So something mild like that, we're probably going to keep continuing the infusion. But if their temperature goes up to, from 98 to 101, that's very clearly a febrile reaction. We're going to stop the transfusion, take all this tubing off, and start a normal saline infusion on clean tubing. We don't just clamp the blood and start infusing this saline, because that's going to push all that blood through. It has to be a fresh set of tubing. And then we're going to start treating their fluids. Most likely this is going to involve the physician coming to evaluate the patient, and all of this blood tubing is going to go back to the blood bank for a lot of analysis. So save everything. Okay? So the big things are stop the transfusion immediately, notify the physician, and then change the IV tubing to start a normal saline infusion. So transfusion reaction signs and symptoms. If you're having an allergic response, here's some symptoms: febrile, hemolytic, but a lot of them, it's like fevers, back pain, shortness of breath, feeling like their airway is swelling. Those 4 questions cover all of these and will get you there. But the big thing is, if there is a reaction, stop the infusion. If you suspect a reaction, step 1, stop the infusion and call the physician. If there's an actual reaction, start a new line of normal saline and try and flush it. Try and dilute it to support the patient hemodynamically. So here's a video on transfusion reactions. Again, I'll put the links down in the description for this video. Step 1, stop the transfusion. I think we've said it like 8 times now. Subtle, I know. Maintain a patent IV line and start a saline solution. Then all of this other stuff is going to start happening. You're going to be monitoring and assessing that patient very closely for the remainder of that shift for at least a 4 to 8 hour window after this has all been stopped. We're looking for vital sign complications. So if they're having a full-blown anaphylactic reaction, that they're hemodynamically stable, and that they're able to maintain their urine output. Because the little beans, little kidney beans, it's the canary in the coal mine. If the kidneys stop producing urine, that patient is not hemodynamically stable, no matter what that vitals machine might tell you. That is a very bad sign. So we always pay close attention to the kidneys after any kind of traumatic or unexpected event. And then you're going to go through the policy to complete any transfusion documentation, transfusion reaction documentation. Antigens, antibodies, so you guys know all the blood types, A, B, and O. The universal recipient is AB because they got all the antigens. Universal donor is O because there's no antigens. So that's kind of the big gist here. Know who your universal recipient is and your universal donor. The other big thing is Rh factor. So A positive, B positive, AB positive, that kind of stuff. If patients have an antigen, it's an Rh factor positive. If they don't, it's Rh negative. So that's a big thing in particularly one population, and that is our pregnant women, especially if there's a positive to negative Rh factor difference between male to female, between different partners. Because the baby can be born with antigens that the mother does not have. This is why we have to give a drug. If we're in this situation, we have to give a drug called RhoGAM during delivery, during that hospitalization for delivery. The reason for that is to prevent future antibody reactions with any future children. For this child, the mom's going to be fine. They're not going to produce antigens for the child's blood type, but in the future, that mother has now produced antigens against that other Rh factor, and RhoGAM will help us to manage that so they can have safe pregnancies in the future. I'll put all the links in the description, but that's it for blood products and blood transfusions.